stress limit is positive, you do cardiac catheterization, as somebody just said. This is an example from the angiogram in the PCR lab. Okay, and they put a stent on it. This is a stenosis right here, and now this is post a stent placement, and now you have good flow. Indication for cardiac catheterization. We talked about that already. Let me keep going. We got that. Oh, by the way, don't forget, when it comes to stable angina, okay, obviously first treatment is lifestyle modification, followed by your beta blocker, nitrates, and calcium channel blocker. When it starts to get to like stage 2, stage 3, that's when we want to do PCI and cabbage.
Dr. Sam.
Yep.
I had a question. In the lecture, when I came from lifestyle modifications to lower blood pressure, my understanding was that the number one way to lower it with lifestyle modifications was the DASH diet. But in the book, it said that weight loss was the number one way. So I guess if you were taking the exam and we were asked to pick what's the best lifestyle modification, which would you pick?
Nobody will ever ask you that question because it makes no sense.
Okay.
The best thing is lifestyle modification. That's it. Meaning that lose weight, eat right. What you eat is more important. How can you lose weight without eating right? You know what I mean? So it just makes no sense. So they're not going to answer that question. The answer is lifestyle modification. Eat properly, exercise, lose weight, and that's it.
Thank you.
But you're right. Dieting is number one, but they won't answer that question. That just makes no sense. What is the number one problem with PCI?
Restenosis.
Restenosis. That's right. Okay. Unstable angina. Okay. With unstable angina, we talked about it already. Okay. But the most important thing is you have to differentiate between unstable, right, to your end-STEMI, because your unstable angina could go straight to end-STEMI and go to STEMI. So I'm going to skip this and I'm going to skip this. Okay. And what I want to do here is to discuss this. How do you diagnose or how do you differentiate between unstable angina and end-STEMI?
Cardiac enzymes.
Cardiac enzymes. Okay. Because unstable angina, you could have a normal EKG, or sometimes you get a ST, you get a ST depression with unstable angina, right? But when the cardiac enzyme is positive, that is your end-STEMI. Okay, end-STEMI. Okay, good job. Prince metal. Okay, Prince metal. Prince metal is pretty much like a renal phenomenon. Always what you see here is that you have a patient, they have an anxiety and they go to spasm. Okay. And the best treatment for that is calcium channel blocker. Now, listen to this. Prince metal is the only angina with ST elevation. The only one with ST elevation. So that means you get confused with Prince metal, with STEMI, and with acute pericarditis. My question is, how do you differentiate between MI and Prince metal?
Cardiac enzymes?
Cardiac enzyme. With Prince metal, cardiac enzyme is normal. Okay? In Prince metal, patients are technically normal. They have no CAD. They have no problem with their heart. Nothing. If you go in and do coronary angiography, ready for this? The vessels are beautifully and clean. They are very clean. No clot, no atherosclerotic plaque. It was beautiful. While you're in there, though, your patient goes to anxiety, whatever, if possible, you will see where the vessel will just stenose on you and open again, Okay, and the best treatment is calcium channel blocker. So what I want you to know here is ST elevation could happen with MI, ST elevation could happen with Prince metal, ST elevation could happen with acute pericarditis. How do you differentiate between acute pericarditis and Prince metal angina? Based on EKG.
acute pericarditis is generalized, like everything's elevated, ST elevation.
That's true. You have ST elevation. That's true. Anything else? It's in the book. I told you to read the book. I'll tell you. Here you go. ST elevation conditions, MI, Prince-Meadow, and pericarditis. With acute pericarditis, you're going to have ST elevation with depressed PR waves. Okay. And on the AVR, you're going to see elevated PR waves. So when you see ST elevation and depressed PR waves, that is your acute pericarditis. Okay. Right. Can you mute, please? Talking?
Thank you. It looks really good.
Who's
Thank
talking?
you guys. You did a great job.
Can you mute? Okay. Prince-Meadow versus unstable angina. Remember Prince-Meadow, okay, you consider arrest. Unstable angina also arrest. With Prince-Meadow, you have to remember they have no CAD, common in female, anxiety, healthy people. And with unstable angina, they have issue of CAD. How do you differentiate between STEMI and NSTEMI?
EKG.
EKG. And you got this already. Oh, this is very important, real quick. On an EKG, when you have a positive ST elevation on AVL, where is your problem?
Lateral.
AVR, where's your problem?
Right side.
AVF, what's your problem?
Inferior surface.
Q wave, what does that mean?
Infarct, previous.
That's right. T wave inversion, what does that mean? Whaling sign.
Anterior wall MI.
Beautiful. Anterior wall MI. Thank you so much. Levine sign, you know what that is already. Let's keep going. Yes, sometimes, there's something called atypical presentation of MI, and you see that in women, elderly, and diabetics. Okay. Let's keep that. I'm going to keep going. Okay. Unstable angina, you have normal cardiac enzyme, and STEMI, elevated cardiac enzyme. STEMI, you have elevated ST elevation. Okay. What is this? Describe what you see and what sign is this? What am I asking? I forgot.
Inverted T.
Oh,
Sign.
good job. Ooh, wow. Who's that?
Luck.
Wow. Salah, you're going to get 100. I'm nervous. You're on fire. Good job. Okay, when it comes to MI, basically PVC. Oh, what does PVC look like? Anyone know?
Is that abnormal P? One of them?
Premature ventricular contracture. That's what that means. Premature. What is it?
Isn't it when the QRS is like widened, a weird shape?
That's right. You got it. It's got a bizarre looking QRS that's widened and it's consistent. Right. So when you get that, these people could develop VFib and VTAC and VFib. What does VFib look like on the EKG?
Scribble.
Chicken scratch.
Chicken scratch. Thank you. Scrabbles. VTAC. What does it look like?
Inverted V's.
That's right. That's right. Good job. Okay. We discussed this already. We discussed that already. What is this? Right ventricular infarct. What's the most common cause of death in MI? What's your answer?
VFib.
That's right. VFib, VTAC. What am I saying here? What's this? What's this? Oh, yes. How do you treat AFib? So let me say this. AFib that is unstable cardioversion, that is stable beta blocker and calcium channel blocker. Let me tell you this. If you're not sure, you always want to do cardioversion first. If you're not sure on the exam, always pick cardioversion on a board exam. When you see AFib, because it's a very bad disease, always pick cardioversion. If they don't tell you patient is stable, not stable, they're not telling you anything, cardioversion. If this patient is stable, that's when you want to go for your medication. And don't forget, you have to put this patient on anticoagulants. Now, listen to this. Anticoagulants is not the first treatment. Anticoagulant does not treat AFib. Anticoagulant treat the problem or the symptoms of AFib. So you have to be careful with that. The treatment for AFib is cardioversion. If a patient is completely stable and they want you to give medication, beta blocker and calcium channel blocker. Same thing in VTAC. Unstable, cardioversion. Okay. Stable, you can give some kind of same thing as your AFib. Okay. Don't forget that. Okay. What is your treatment for AFib? Okay. I told you to know everything about this. The mnemonic is not my mnemonic. I got it from online somewhere. Mnemonic is A, B, C, D, E for AFib. A is anticoagulant. Put them on anticoagulant because you worry about stroke. Number two, you want to place them on amiodarone, arrhythmias, which will convert the AFib to sinus rhythm. So amiodarone, beta blocker, calcium channel blockers to control the rate, the Jackson to control the rate, cardioversion. You see what I just said right there is the best. It is the best, especially when the patient is unstable. Don't forget your charge risk. What is the treatment of choice for acute pericarditis? Aspirin first. Always aspirin first. And let me give you a mnemonic. Acute A, aspirin A. Acute A, aspirin A. Always that goes first. Aspirin goes first. Okay, that's not helping. You want to add NSAID. You can put colchicine on top of that. If that's not working, then you put steroid. Okay, but you got to be careful with steroid. You can get a rebound. Okay, pericarditis. So you go in that order: aspirin, NSAID, colchicine, and steroid. Dressler syndrome is something called post-MI, pericarditis. So after MI, you develop pericarditis because of Dressler syndrome. How do you treat it? Same thing, aspirin. Remember the charge, okay? The charge risk, C, CHF, hypertension, A, down and on. That's in the book. Make sure you review that. Pretty much just telling you that what's the risk of a patient developing stroke, especially when the patient have a history of AFib. Okay, it's called charge risk. Okay, know that, please.
Dr. Sam,
Yes.
for the CHADS risk, do we have to know? I think I read in the book, maybe somewhere else, that if it's, I think, over 4, you have to use like a systemic one, anticoagulant versus like warfarin, versus if it's like under that, you can use aspirin.
Ready for this? The only thing you have to know is what does CHAD stand for? The CHAD stands for a risk to determine if a patient will develop a stroke, okay, on a patient with a history of AFib. That's it, okay? And the higher the CHAD risk is, the higher the chance of stroke, that means you must place them on anticoagulant. That's what the CHAD is all about.
Okay, thank you.
That's it. When it comes to MI, you want to use fractionated heparin as compared to unfractionated heparin. Okay, so low molecular weight as compared to unfractionated. That's what's better. Okay. I'm going to stop here. Oh, this is good. Yeah, that's the same thing. Real quick, cocaine-induced cocaine-induced MI, okay, and Prince metal, they have the same treatment. Watch this: calcium channel blocker, calcium channel blocker. Cocaine will induce coronary heart vasospasm. Guess what? Prince metal. Okay. So when you see anybody taking cocaine and they ask you what is the best treatment, calcium channel blocker. Cocaine induced, think of Prince metal. Okay, Tilak, you ready for me?
Sure.
Let's do it again. Which population will commonly have an atypical presentation during acute MI?
Elderly females.
Women, elderly, and diabetics. Good job. What is the treatment of choice in a patient with cocaine-induced MI?
Calcium channel blockers.
What is the treatment of choice in patient with Prince metal?
Calcium channel blockers.
Good. True or false? Patient with Prince metal, they have CAD.
Could you repeat that? I'm sorry.
Patient with Prince metal, versus spastic angina,
Mhm.
they have history of CAD.
The vessels look beautiful. No.
That's right. Beautiful. Thank you. An inferior wall MI will be seen in what lead?
2-3 AVF.
Beautiful. Which cardiac biomarkers peaks the fastest? Peak the fastest, not the best.
Is that the myoglobin?
That's right. Myoglobin.
Nice.
Myoglobin peaks the fastest, but they don't use it anymore. The answer is always going to be troponin. Post MI pericarditis, you have to use aspirin to reduce the inflammation. What do you call that?
Dressler syndrome.
Beautiful. Excellent. Guys, can you take a 5 minutes break? I want to answer this question real quick. Somebody's calling me. Sorry. I'm so sorry. I'm back. Are you guys still here?
Yes.
Yeah.
Sorry about that. I had to take a call. I'm on call this week. I did a couple of surgeries already this morning. One this afternoon, and they just called me again. And I'm like, geez, you want to kill me. Anyway, so acute pericarditis. What you have to know here is very simple. Number one, what is really happening? You have inflammation around the pericardial sac. Okay. So this is a pericardial sac right here. You have inflammation, not fluid, just inflammation, right? So basically, what's going to happen is that this happens most of the time after viral. When you see viral something, flu, viral, GI viral, anything viral, and they say patient, actually in position to get better, that's a dead giveaway that they are telling you acute pericarditis. Okay. And the next thing you're going to look for is something called pericardial friction rub. Okay. When you get that, you're done. That's acute pericarditis. Okay. Now, another thing you have to look for on the EKG, that's very important, is that you remember this is one of the cardiac problems that will give you SC elevation, SC elevation with MI, SC elevation with Prince metal, SC elevation with acute pericarditis. Okay, but what makes acute pericarditis so different is that you're going to have ST elevation, and happen at the same time, you're going to have PR depression. Okay, now on the AVR, you're going to have PR elevation. But the one that's very important to differentiate this from your regular, what you call it, regular MI, is that ST elevation and PR depression. Now watch this. There's another condition that could also give you ST elevation, or I call it peaked T wave, and a flat P wave. What's your diagnosis there?
Hypokalemia.
Right. So hypokalemia could also act like your acute pericarditis. That's why you need to check your AVR to see what's going on with the PR. If the PR is elevated in your AVR, that is pathognomonic for acute pericarditis. Does that make sense? Are we good? Anyone confused? No? All right. So let me keep going. So another thing you could see with acute pericarditis is that electrical alternance. Electrical alternance is very common in pericardial effusion and cardiac tamponade. Very common, right? You can also see it with acute pericarditis, right? Echo is great for diagnosis, but not the best because, again, it's an inflammation. Okay, it's an inflammation that you're seeing. So echo is not the best. EKG, it is good for this. Physical examination is good for this. But when you have acute pericarditis, when now you have increased effusion around it, increased fluid around it, at that point, echo becomes the best. The best treatment for acute pericarditis is aspirin, followed by ibuprofen, followed by a colchicine, followed by an NSAIDs, and followed by steroid. So right here on the EKG, you could see your ST elevation, and you could see PR depression right here. And your AVR, you see elevation of the PR. Classic. Okay, I'm gonna keep going. Recurrent pericarditis. Recurrent pericarditis happens to people that refuse treatment, or the treatment is not good enough, or the dose is not good enough. And the definition of that is when you have at least recurrent episode 4 to 6 weeks after the end of the initial one. So every 4 to 6 weeks, you are getting pericarditis. That's called recurrent pericarditis. And the best treatment for that, again, is, aspirin. So this is a cascade. I made this one. This is me. I made this. So acute pericarditis, you get that, aspirin. If you don't get it treated properly, or patient not taking medication, you're going to get recurrent pericarditis, 4 to 6 weeks. Okay. Treatment, again, aspirin. If not working, you can give colchicine or ibuprofen. If you're not careful, your recurrent pericarditis will lead to pericardial effusion. If you're not careful, pericardial effusion will lead to cardiac tamponade, and where you're going to get your Kussmaul sign, and you're going to use an echo to diagnose it. Okay. So constrictive pericarditis, what do you see with that? Fibrosis. So you have decrease. So constrictive pericarditis kind of look like your restrictive cardiomyopathy. They're kind of same thing. Okay, same thing. And if you look right here, remember that Kuzma sign? You see Kuzma sign with constrictive, boom, right there. Restrictive and also right ventricular infarction. So when you think of constrictive pericarditis, think of restrictive cardiomyopathy. Okay, all right. Pericardial effusion. When you think of pericardial effusion, just know it might end up with your cardiac tamponade. So I'm not going to go straight to that. Okay. So with cardiac tamponade, what is really happening is that you have a lot of fluid around the heart. Okay. And there's a mnemonic that you must know. It's called the Beck's triad. Do you guys know what that is?
No.
Ajay, do you know what that is? No?
I'm not sure.
Okay. You have to know. Man, the exam, some of you guys know that. That's scary. Well, that's fine. I'll teach you. Beck's triad, okay, is pathognomonic for cardiac tamponade. Beck's triad, cardiac tamponade. Basically, if you think about it, what you see in these people, imagine you have a lot of water right here. You have a lot of water. You have a lot of water around the heart. A lot of water around the heart. Okay. What's going to happen with the heart sound? Will it be normal or muffled? Right? You can see them. Sometimes you can see it will muffled. Aortic stenosis, or because you have a lot of water around the heart, muffled. So what's going to happen to the cardiac output? You think the cardiac output will be increased or decreased? You remember you have water that is constricting, that's squeezing the heart. Water is squeezing the heart. So if water is squeezing the heart, can the heart pump properly? No. So you're going to get hypotension, muffled heart sound, and elevated JVP. Why elevated JVP? Because your heart is so squeezed that everything in the left ventricle will back up from the left to the lung, from the lung to the right, and back to the vein, back to the jugular vein. That's the reason why you're going to get, your Kuzma sign, your elevated JVP on inspiration, Kuzma sign. So this is a Beck's triad. Beck's triad is hypotension, muffled heart sound, and elevated JVP. That's Beck's triad. Okay. Another thing you see in cardiac tamponade is something called pulsus paradoxus. Remember, I was telling you earlier that there are three conditions that will give it different blood pressure. On the upper extremity, you have higher pulse, lower extremity, you have lower pulse. Higher extremity, you have hypertension, lower extremity, you have hypotension. So cardiac tamponade, I'll give you that. And that is called pulsus paradoxus, meaning that there are different pressures between the extremity. So the upper extremity pressure is different from the one lower extremity. So that's called pulsus paradoxus. You can see that in coarctation of the aorta. You can see that in Takayasu vasculitis. Okay, there's something called the heart sign, the Hewitt sign. Hewitt sign. And what you see with that is increfemitus, bronchial breathing, and the most important thing is dullness to percussion because of so much water. Dullness to percussion beneath the left scapula. Okay, so these are the things you see in cardiac tamponade. So anytime you see a patient with pulsus paradoxus, hypotension, muffled heart sound, elevated JVP, okay, pulsus paradoxus. Not they mention is your electrical alternance. You also see that in cardiac tamponade, electrical alternance. You see that in cardiac tamponade or perfusion. Okay, so that's very important. Okay, right here, cardiac tamponade. What do you see on the X-ray? You see water bottle appearance, which is the same thing you see, in pericardial effusion. EKG, you're going to see that electrical alternance, electrical alternates. You see that in pericardial effusion, and you also see that in cardiac tamponade. Okay. Cardiac tamponade means there's bleeding around the heart and there's fluid around the heart. And the best you want to do is to do pericardocentesis. That's your treatment. True or false? Cardiac tamponade could lead to cardiac shock, cardiogenic
True.
shock. That's right. True or false? Cardiac tamponade could lead to obstructive shock.
True.
That's right. Okay. So here, what I was saying is echo, all congenital, anything fluid around the heart, all valvular disease, congestive heart failure, you want to do echo. Don't forget your electrical alternates. There is different amplitudes of the QRS waves. You see this in cardiac tamponade, pericardial effusion. Okay. Oh my God, I'm tired. It's a lot. All right, you guys know this? Your stage 1, stage 2, right? We're good?
Yeah.
Okay.
Yeah.
Let's keep going. It's a lot of information. Jeez. Okay. You guys know this already. You know, the atherosclerotic cardiovascular risk. Okay. Pretty much just telling you, when to put the patient on statin. And you could combine that with the treatment of high blood pressure to really give you the best optimal treatment for your patient. Okay. I'll keep going. Okay. You have to know this, and I think they discuss in class. When you have blood pressure that is normal, you don't do nothing. No treatment, lifestyle modification. By the way, everything in lifestyle modification, the first treatment is lifestyle modification. First treatment, lifestyle modification, okay? If it's elevated, okay, again, lifestyle modification. If it's stage 1, you want to do lifestyle modification and give them monotherapy, one medication. If it is stage 2, you want to do dual therapy, 2 medications. Okay. All right. The next one I want to talk about is so important. I think it's about like 10 questions on this. Okay. When you have hypertension, what's the first line treatment? Lifestyle modification. In patients that are pregnant, preeclampsia, okay, the only 2 hypertensive medication we want to give them is beta blocker and hydralazine. That's it. Nothing else. Nothing else. ACE inhibitor, you want to make sure you never give ACE inhibitor to a pregnant woman because it will cause them to or abort. It will cause a lot of problem with the pregnancy. The patient can lose their pregnancy. So never give ACE inhibitors to pregnant women. Only beta blocker and hydralazine. That's it. When it comes to the first line treatment for hypertension, it depends on the patient. If the patient is healthy and they have no issue, no problem, just hypertension, you want to start with thiazide. Thiazides are your number 1. Your diuretics are your number 1. Okay? That's your number 1. Okay? If the patient is diabetic, because they're diabetic, you want to protect their kidney, you want to start with ACE inhibitor. So ACE inhibitor is your number 1 initial treatment for diabetics. So people always get that confused. Don't get confused. Diuretics is for everybody, first line. Okay? If they have no other issue, healthy, whatever, this is the first time they've been diagnosed with diabetes, being diagnosed with hypertension, you do thiazides. But when it comes to diabetics, ACE inhibitor is your first line. Then your second line usually is your beta blocker. Your third line is your ACE. But if the patient is diabetic, ACE is number 1. If the patient cannot take ACE inhibitor, then you want to give them herbs. And number 1 complication with ACE is coughing. So if they're coughing while you're taking ACE, you stop it and you give them herbs. Calcium channel blocker. Okay? Calcium channel blocker. In patients that have osteoporosis, you could give them calcium channel blocker. That could be their first line treatment. So your elderlies, right? Give them calcium channel blocker. All right? Don't forget, calcium channel blocker could be used to treat Prince metal, could be used to treat cocaine-induced MI. People that have BPH, you want to give them alpha 1 blockers. BPH, alpha 1 blockers. Okay. All right. So let me go over ACE inhibitors. The mnemonic is called captopril. The number one problem with ACE inhibitor, coughing, angioedema. See this one right here? Pregnancy, pregnant problem. So that's why you never, ever wanted to give a patient, okay, that's pregnant, ACE inhibitor, and down the line like that. Hypertensive emergency and hypertensive urgency. The difference is end organ damage. This has end organ damage. This needs IV blood pressure medication. This needs PL. Okay. You want to make sure you don't reduce blood pressure more than 25% within an hour. You guys remember this? Make sure you know it. Okay. What is really important here is there is something called secondary hypertension. Okay. What could lead to secondary hypertension right here? So, what do you have to screen for secondary hypertension? People that have a drug resistance, people with abrupt onset of hypertension at the age less than 30. So people that are less than 30 don't get hypertension or don't become hypertensive. If they are, you want to rule out secondary hypertension and everything here. Okay, walk them up. So with people with secondary hypertension that are listed here, you want to make sure you rule out aldosteronism. What is the function of the aldosterone? The function of the aldosterone, right, is to retain water and retain sodium and remove potassium. So if you have a patient that is less than 30, and you notice that they have recalcitrant hypokalemia, you better make sure you order aldosterone level and renin level. Aldosterone level, if it's really, really high, that's primary aldosteronism. If the aldosterone level is low, is high, and your renin is high, that means that you have a secondary, okay, aldosteronism. So that's very important. You should know that. Any questions?
I had a question, Dr. Sam. What is it like the value for the aldosterone to renin ratio that would lead you to diagnose primary aldosteronism?
Right. So basically, usually it's like 2 to 1, somebody 3 to 1, meaning that so basically in your adrenal cortex, basically you are producing aldosterone, right? Also, don't forget, your renin, just put it by the kidney, your renin could also stimulate the release of aldosterone, which is called secondary hypoaldosteronism. Okay, so usually you want to combine both, and what you want to look for, the ratio of aldosterone should be a little higher than renin, and that will give you your primary aldosteronism. Like 2 to 1, 3 to 1.
Okay, thank you.
Okay. Renal artery stenosis. When you have stenosis of the renal artery, you're going to get hypertension. The best treatment for that is to do revascularization. And one of the biggest problems with, your percutaneous renal artery angioplasty, stenosis. You guys know that already. Don't forget, you want to make sure you get that blood pressure below 130. That's the recommended level. I talked about this already. If a patient is stage 2 hypertensive, 2 medication, stage 1, 1 medication with lifestyle modification, okay? Please listen to this. Never stop beta blocker on your patient. Continue taking it. All medication that protects the heart, you never want to stop them. Your beta blockers, your calcium blockers, all this medication that protect the heart, you don't want to stop them. Just continue taking them, especially the beta blockers. Don't stop them. Okay. The exception to the rule is your ACE inhibitor and also your diuretics. Let me just go back. Let me go to this right here. So if you look at this list, right, diuretics, ACE inhibitors, angiotensin 2 receptor blockers.
Okay, I found this on the web for bitters and education 2 receptor.
So basically, if you look at this medication, they really protect the heart. You don't ever want to stop those. Continue taking them, which include beta blocker. Diuretics, ACE inhibitors, and herbs, you could hold them on the morning of surgery. And the reason why you want to prevent hypotension, risk of hypotension, want to prevent that. So diuretics, ACE inhibitor, and herbs, those are the ones that you have to order on the day of the surgery. Now, let me tell you this, for the exam, you have to just memorize this. For me, what I tend to do is like I have my cheat sheet, I just look it up. So, but for you guys, sorry, you have to just memorize it. What else? Don't stop beta blocker. We talked about that already and discussed that. EKG. I'll skip that. Okay. Low risk, intermediate risk, and high risk. If you look right here, this is where we fall. This is podiatry right here. We are in minor surgery. So your amputation, your bunions, amatoes, and stuff like that, we are here. Okay. Flap recon, we are here. Okay. Now, if the patient has a lot of comorbidities, we could get advanced into intermediate. But patients get a BKA and stuff like that, those are your patients, that could be intermediate and high risk. But if the patient has acute limb ischemia, so all your emergencies, cancers and stuff like that, your acute limb ischemia that leads to amputation, those are high risk. Okay, all your emergencies will be here. So you can now say, what if I have a gas gangrene? Isn't that considered, high risk? But guess what? With a gas gangrene, that could go between intermediate and high risk because the patient has an emergency, So the farther you're away, from the heart, basically your risk gets lower, but again, it depends on comorbidities. So anyway, when I'm talking for podiatry, we are here, we are low risk. Okay. If there's some kind of comorbidities, then we get advanced into intermediate. This is where we stop. We're here between these two right here. If you're gonna go high risk, then you want to start thinking about your acute limb ischemia, which is for like pretty much vascular, really. When should you stop clopidogrel? Right here. So acetaminophen, you never stop it. Aspirin, you want to stop at 7 to 10 days, right? NSAID, three days prior to surgery. Clopidogrel, 7 to 10 days before surgery. So NSAID, aspirin, clopidogrel, 7 to 10 days, NSAID, 3 days. Now, sometimes, you want to continue aspirin. Sometimes you want to continue aspirin, especially when the patient's got some kind of cardiac issue, you protect them, and you're doing a very low risk procedure like ingrown toenail, arthroplasty of the toe. You want to continue aspirin. All right. But basically, the recommendation is that when it comes to aspirin, clopidogrel, 7 to 10 days, and NSAID 3 days.
Dr. Sam.
Yeah.
Sorry, going back to the low, intermediate, and high risk procedure. Yes. Did I understand you correctly that even like a TMA would be under low surgical risk if the patient doesn't have a comorbidity associated?
Yeah, low risk.
All right, thank you.
But if they are diabetic, which all of them do, they're diabetic, they have CHF, they have all this crazy disease, renal problems, then they are going into intermediate. So that's what I'm saying. For podiatry, we are between low risk and intermediate. Usually we're not here.
Okay.
We're between here, just two.
Thank you.
All right. Okay. Oh, I want to see something here, right here. A patient that's got an MI or they have some kind of MI procedure within 6 months, you should delay any kind of elective surgery for at least 6 months. Okay. Okay. So almost done. So basically, you want to make sure in your patient, you don't want the blood pressure to go below 20% of their baseline. Stay away from NSAID because that will cause some kind of cardiovascular risk. Okay. Aortic dissection, you know that already. I'll go to depth about that. Aortic dissection, you know that already. Let's keep going. Oh, yeah. abdominal aortic aneurysm. Basically, you have a rupture of the abdominal aorta. Basically, you're going to get that Gray Turner syndrome and Cullen sign. Cullen sign, the way I remember it, C is in the front, G is in the back. So Cullen sign, boom, in the front, about the umbilicus, Gray sign in the back, about the flank area. Okay. The main thing you have to know about this is that when that AAA, okay, is more than 5 centimeter, some people say more than 5.5. But when it's more than 5 centimeter, you want to do surgery. Okay. If it's less than that, you don't. Don't forget your PAD. Okay. Know your PAD very well. Okay. If a patient has a normal ABI, resting ABI, you want to do exercise ABI. If the patient has a very bad ABI, like your 0.5, 0.4, 0.3, that's pretty bad. At that juncture, you want to go and get an angiogram and do endovascular or bypass on these people. Acute arterial occlusion, also called acute limb ischemia, your 6 Ps. Okay, don't forget that. DVT, we know that already. I won't go into depth about that. The main thing I want to focus up here is when you have chronic venous insufficiency, you have edema, you want to control that edema. Okay. Now, this is different between superficial thrombophlebitis and DVT. Superficial thrombophlebitis is really caused by infiltration, like your IV lines infiltrated. You don't need antibiotics for that. You don't need anticoagulant, just NSAID, elevation, warm compress, and that's it. Okay. All right, let me skip that. What else do I have here? Pneumothorax, you guys know that already, right? Pneumothorax. Okay, so let me do the last one and I'm done and I'll do some questions and we are finished. It's a lot of information. Am I going too fast, guys?
No.
No, sir.
Okay. I hope I'm doing okay as a podiatrist to teach this stuff. Okay. All right. This is the last one. I think it's about like maybe 3 to 5 questions on this. Not much. Okay. So you have shocks. What is shock? Shock pretty much means that you have low blood pressure. When you think shock, think of low blood pressure leading to hypotension. Remember in email, we talked about, shock as anybody with blood pressure less than 90. Okay. So hypotension. Okay. So there's less perfusion to the local tissue. Okay. So basically, what are the signs and symptoms of shock? Anybody want to tell me? What do you see?
Confusion.
Okay, that's right. Automatic
Lightheadedness, pallor,
That's good. Keep going. Tachycardia. Thank you. But your number one answer should be hypotension. That's your number one. Hypotension. That's myself. Hypotension, tachycardia, tachypneic, oliguria. That's important. And automatic status. You guys said that already. So hypotension, tachycardia, tachypneic, and oliguria. This is the best way to monitor your patient to see if they're getting better. Oliguria. Okay. And don't forget, patient with shock, you got to do your A, B, C, D, E. Okay. So treatment of shocks, you want to stabilize the patient, give him some blood work, do some blood work, start IV, give him some Sensodyne if needed. A patient that needs that's in shock, they need bolus of fluid. Okay. They need bolus of fluid. But the only exception to the rule is with cardiogenic shock. Why is that? Why do you want to stay from giving more fluid in people with cardiogenic shock?
because their heart's already failing. We don't need to
That's
give it more
right.
fluid.
Right. So when you give more fluid, you're increasing afterload. With cardiogenic shock, there is no problem with the blood. The blood is getting there. The problem is the engine. The heart is not beating properly. Something is wrong with the engine. So if you give more fluid to an engine that's not functioning properly, guess what's going to happen? It's going to die faster. Okay. So you're going to monitor these people. Okay. So when it comes to shock, the first thing that happens is your blood pressure goes lower. What is blood pressure? Blood pressure is resistance to flow, which is called a systemic vascular resistance times cardiac output. That's your blood pressure, right? you could divide cardiac output into two. Cardiac output is your heart rate times your stroke volume, and keep on going like that. So basically, these are different types of obstructions of shocks that we have. The first one is cardiogenic shock. Cardiogenic shock, meaning that your heart is diseased, but you have good blood going to it. Because your heart is diseased, you're going to have low blood pressure. So that means every single shock you have, you're going to have low blood pressure. Okay? But the difference is cardiogenic shock, your heart is diseased. With hypovolemic shock, your heart is fine, but we have low volume getting to the heart because we're losing blood. We're losing something, losing fluid. So there's low blood going to the heart. So you're going to get low blood pressure. Obstructive means that something is obstructing blood from getting to the heart. By the way, FYI, obstructive shock is same thing as cardiogenic shock. Obstructive shock leads to cardiogenic shock. Okay, so the only difference is that there's an obstruction that is preventing blood from getting to the heart, whereby cardiogenic shock is there's a disease with the heart. With the obstruction, okay, there is something affecting the heart, not the heart itself that is diseased. Distributive, there is three types of distributive. You have the septic shock, you have the anaphylactic shock, and what's the last one? Anybody know the last one?
Neurogenic.
Neurogenic. Good job. Okay. So basically, what you see with all these people, hypovolemic, cardiogenic, and obstructive, you're going to see low cardiac output, cold feet, mottled blue, lack of blood flow to the kidney, right? For distributive, the first thing you're going to see is warm flush skin. Warm flush skin, that's what you're going to see with distributive initially, then later on they're going to become same thing as the other ones. With hypovolemic, cardiogenic, and obstructive, you're going to see vasoconstriction, whereby in distributive, you're going to see vasodilation. Okay? All right. So cardiogenic, the heart is not working. Distributive, these three right here, leading to vasodilation. And this one, hypovolemic. Okay? Peripheral vasoconstriction, These three right here gives you peripheral vasodilation. Okay? Again, increased vasodilation. These vasodilations increase because of mast cells and histamines. This is increased because of infection, okay, and cytokines. This vasodilation is increased because you do not have sympathetic tones. You only have parasympathetic, okay? So sympathetic tones is gone. I'm gonna keep going, go faster. I'm gonna skip all this so we finish all time. I'll skip that. Oh yeah, don't forget, right here, okay, we talked about this, stage 1, stage 2, stage 3, stage 4 from IMED, okay? And the best thing for hemorrhagic shock, especially the one that is caused by bleeding, let me go here. Right here. If it's caused by bleeding, you give blood. If it's caused by just diarrhea, burn, salt wasting, dehydration, give fluid. Okay? I just want to finish this. Almost done. We discussed this in IMED already. Okay, question and intakers. Jugular vein pulse is only elevated in what two types of shocks?
Cardiogenic and obstructive.
That's right. Good job. Excellent. So let's do this real quick and we're going to end it. I think this is it. This is the last one. Let me see. We have some questions. This is the last one. Okay. Okay. So let's do it together. with cardiogenic shock, right? What will happen to the cardiac output? Increase or decrease? Anyone?
Decrease.
Cardiogenic shock.
Decrease.
Guys, listen. When you have shocks, your cardiac output is decreased. Everything is decreased. The only exception to the rule, and I'll tell you why in a minute, is septic shock. And I'll tell you why in a minute. I'll tell you why. But think of everything decreased in shocks. The only exception to the rule is septic shock. Everything is decreased. So let's do it together. So cardiogenic shock, meaning that your heart is not pumping. If your heart is not functioning, you're going to have decreased cardiac output. Make sense? So the body wants to compensate for it. Remember, your cardiac output equals heart rate times stroke volume. So what's going to happen to your heart rate in cardiogenic shock? It's going to go up. Okay. There is something called central venous pressure. Okay. Also called the right atrial pressure. Okay. And this is called the left atrial pressure or Swan-Gon. That's what they call it. Or pulmonary wedge pressure. Kind of measures the pressure within the left atrium and the ventricle. Okay. So basically the pressure in the right atrium is going to be high because what's happening is that the heart is not functioning properly. So blood is being backed up, okay, to the left ventricle, to the left ventricle, to the left atrium, to the lungs, and back like that. So what you're going to see in these people, that's why in cardiogenic shock, you're going to see increased JVP, okay? So CVP is going to be high. PCWP is going to be high. Systemic vascular resistance is going to be high. And your pulsars, because basically you're having decreased cardiac output, is decreased. Hypovolemic. Why do you have decreased cardiac output with hypovolemic? Anyone?
There's a loss of blood volume.
Exactly. So you're going to get increased heart rate. And again, everything that's going to, when it comes to CVP and PCWP, the only time they're going to be increased is for cardiogenic. Everything else can be decreased. Okay. Neurogenic. This is also down. But when it comes to heart rate, why do you think the heart rate is low in neurogenic?
There's loss of sympathetic tone.
That's right. That's the answer. That's the answer. Good job. And with anaphylactic shock, you got the answer. Now, when it comes to septic shock, why do we have increased cardiac output? Well, the reason why we have that is because remember, we have an infection. Guess what's going to happen? We're going to produce more WBC. We're going to produce more blast, more left shift. Because of that, that will cause increased cardiac output. And later on, it's going to go down lower. Okay. Also, O2 sat, okay, will be elevated. Why would the O2 sat be elevated? Because again, you have free radicals of oxygen. Free radicals. That's why it's going to be elevated. They're not good oxygen, bad oxygen. Free radicals are going to be elevated. Okay. Why is the SVR low in septic, neurogenic, and anaphylactic?
Because of the vasodilation?
Because of vasodilation. That's right. Okay. So that's it. What I want to do now is go over some questions on blood vitals to test our minds. And we go from there. Did I lose you guys?
Nope, still here.
I should be the one to be tired. I mean, you guys been studying all day, so you should be tired too. So I feel you for your pain. The reason why this course is so hard is because PARI, they want to make sure we're on the same level as DOs and MDs, and they are testing this on the exam. They're testing this on the exam. Can you guys see the blood vital?
Yep.
Okay. So the question is, what is the electrical axis of the cardiac activity represented below?
Left.
Well, I'm not sure. Let's see. This is going up. AVF is going down. This is going down. You say left. Everybody agree, disagree? Now, I'm not sure who answered that question. Do you think you'll be able to have answered that question before my review?
No.
No, I asked that question. I just want to make sure, for me, I just want to make sure that, I'm giving you guys a good review here and I'm not wasting your time. To me, it's very important. I'm not wasting your time. Okay, good. That's good. Excellent. Let's go to the next one. What is the most common cause of this ECG? What causes ECG? So as you go to lead 2, what do you see? What do you notice?
Electrical altering.
Alternating electricity.
That's right. So where do you see this? Tell me 3 different cardiac problems that you see this.
Pericardial effusion.
That's right. Tamponade. Anything else?
Effusion.
Effusion, right. So your answer is what? Right? D,
D.
right? Right? Makes sense? Okay, let's go to more questions. Let's do mummers. Let's do mummers because there's a lot of questions on mummer. I want you guys are good with mummers. My app is to make sure you guys pass and do well. I don't want you guys to go on the exam and fail. So let's do this one. Okay. All right. You have a 14-year-old otherwise healthy male. Okay. Just by hearing that alone, what's your answer? Just by hearing a healthy male.
Welcome.
Exactly. Just by hearing it alone. But anyway, let's keep reading. And it says you have a systolic ejection murmur, crescendo, decrescendo systolic ejection murmur, right? And it said this is best heard at the apex and the fourth in the space, whatever. And denies that, there's something that I'm looking for. So what gave it away that this is Ockham?
14.
14. Anything else?
Football practice.
Football practice. Anything else?
Crescendo, decrescendo.
Yeah, exactly. Yeah, exactly. Okay. Good job. Okay. Let's go to the next one. This one. So if you look right here, it says holosystolic murmur. Can you give me 3 holosystolic murmur that I talked about? Remember that MTV?
ASD, VSD, and tricuspid regurg.
So what's your answer?
B.
That's right. Boo. That's it. What do you see here with patent ductus arteriosus?
It's the machine murmur.
That's right. What do you see with this one? Ejection murmur, right? What do you see with this one? Pulmonary stenosis. What do you see?
Systolic crescendo, decrescendo.
That's right. That's right. Go to the next one. Let me give you a clue. You see what they're telling you? Squatting, increase restraining down from Basava. When you're hearing that, what they're telling you?
Holcomb.
That's right. That's what they're telling you. Remember, I said it. When you have, if the murmur is increased Vasava, you're done. That is Ockham. Case close. See, they're trying to trick you. Aortic stenosis will give you the same murmur, but once you do your Vasava, it's your Ockham. Don't waste your time. Case closed. Keep going. Which following murmur occurs during systole?
Aortic stenosis.
D.
So how come you didn't think about it? Just said it. Boom. Right? You see that? So I guess the review is helping a little bit. No?
Yes, sir.
Okay, let's go to the next one. Let's go to the next one right here. Again, this is not my question. This is ball vitals. Where is a murmur associated with aortic stenosis best auscultated?
A.
Right. The right second inner space, because we're talking about apartment M, right? Straight to the point. Good job. Excellent. Let's go to the next one. I just did that. So this one. You have a patient with diastolic decrescendo murmur. Remember that? What's the valvular disease?
Regurg.
Right, aortic regurg, right? So what do you see with that?
Quincke pulses.
Ankle pulses, Corrigan pulse, de Musset, Austin, all that stuff. All right? Right? Make sense? Beautiful. You guys are good. Last one. You have a patient with crescendo decrescendo murmur, best heard right upper sternal border, right upper sternal, and you go to the carotid. Case closed. You know the answer.
Aortic stenosis.
Booyah. Excellent. Good job. Let me see. What else do I have here? ECG. Well, we did that already. Okay, what do you see here? Let's do it together. Look at the distance between RR. Equal or not equal?
Equal.
Come on. Look.
Do
This
you
is
mean the peak of the QRS? I thought that's what you were asking.
my fault. The distance between R or R interval, equal or not equal?
Not equal.
Not equal. Look at this. Distance from here to here. Distance from here to here. They're different. It's different. Okay. That's number one. Number two, you have some stuff going on here, multiple waves here. Sometimes you don't know see some of the P's. Okay. So anytime you see this, when you have unequal R to R interval, okay, and sometimes you can't even see the P's because it's kind of like, the P's there, but it's buried. And here you can see you have multiple P's, okay, with this wide RR here. When you see that, what is that telling you?
Fib.
It's AFib.
AFib. That's right. Does that make sense? So your AFib, pretty much what you're looking for is sometimes you're not going to see no P's, and sometimes you're going to see these multiple P's. But the main giveaway is that your R to R interval is going to be out of whack. Make sense? Okay. Go to the next one. This is hematology, endocrine. I'll give you something. Okay, good. This is a good one. This is a good one. Which of the following diagnostic tests is used to confirm a diagnosis of coronary heart disease? Confirm.
EKG.
BMP.
Can BMP confirm a diagnosis of coronary heart disease? What is BMP for? What is that for? BMP.
CHF.
Is CHF a coronary heart disease?
It can lead.
It can lead to it, but it's not. But again, is BMP a diagnostic test?
No, it's just an indicator.
Right. What about resting ECG? Resting.
So exercise stress test.
Right. Remember when you have, a patient that's got a, unstable angina, technically when a patient got a stable angina, okay, during rest, that's not really telling you much. You want to stress them, and when that stress is positive, that's the diagnosis for coronary heart disease. Okay, so stress test is number one. Just like when you have your ABI, resting ABI, and exercise ABI, your resting ABI is not a true ABI. Your true ABI is your exercise ABI. So same thing here. your exercise, ECG, echo, those are your diagnostic tests to diagnose coronary heart disease. Okay. All right. It's too much reading. I want to get you guys out of here and find something else. All right. Let me see. What else am I missing? I'm gonna just stop there. You guys got it. So listen. Any questions for me?
Yes, can you clarify, this is back when you were talking about where chest x-rays were done, and the rule of thumb is in diagnosing cardiac or heart issues, specifically the heart itself dysfunction, you do an echo. But there was one case where you did a chest x-ray first instead of an echo. Which was that?
I did a chest x-ray before echo.
Yeah, it was back when you were talking about, what do you do first? And then in the case
Okay.
no, I know pneumothorax is for a chest x-ray, but it was a heart condition.
Oh, it's CHF. I got it. I remember.
Thank you.
Yes.
Okay.
So with CHF, listen to this. If they ask you what is the best initial diagnostic test for CHF, your answer is chest x-ray, not EKG, chest x-ray. Now, if they give you chest x-ray already, then your next best, I guess, your best initial now at that point is going to be an echo.
Thank you.
All right. So
Dr. Sam.
yes, go ahead.
Sorry, I just had a question. Sorry if there's like a lot of like work for you to answer, but when it comes to on EKG, distinguishing between sinus arrest, sick sinus syndrome, and Mobitz type 2, do you have any advice on how to approach that?
That's a great question. So when it comes to sinus arrest, what you're looking for is there's a pause, 3-second pause, meaning there's flat line. So you're going to get normal sinus rhythm followed by a 3-second pause. You understand that?
Yes, I do. Thank you.
That's your sinus arrest. That's how let me see if I can find it. That's how you could diagnose that. Let me show you. Share my screen. Let me now go to here, control find, sinus arrest. I can find it. Good, perfect. Can you see this?
Yes.
So this is your normal sinus rhythm going on here. Normal sinus rhythm, blah, 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 and all of a sudden, a 3-second pause. Then it start again. So when you see a normal sinus rhythm and a 3-second pause like this, a flat line, that's your sinus arrest. Right? And the second one you ask is what?
Sick sinus syndrome?
Sinus syndrome?
Sick sinus syndrome, yes.
Yeah, I don't have a sample here. I have an example here. And I don't think that's on the exam. The other one you asked about was I think block, I think. What is it?
The Mobitz type 2.
Oh, Mobitz type 2. Good. Mobitz type 2. So
sometimes the
yeah.
No, go. I was just gonna say sometimes, like when I was looking at EKGs online, the sick sinus syndrome and the Mobitz type 2, I was like confusing sometimes.
Yeah, I'll just stay for now. Stay with the sinus arrest and also stay with the second degree heart block type 2, which is a Mobitz type 2. Is that what you're talking about? Mobitz type 2?